everybody to the Epilepsy Center's Living with Epilepsy series. Today we have a great discussion today about epilepsy in the elderly. And we have Nicole Giudice, and she is the Vice President of the Board of the Epilepsy Center in Northwest Ohio. And she is a physician assistant and has spent over 10 years in the field of neurology, and she has a great passion for educating her patients and families on neurological disorders. And she is going to be talking to Dr. Saraiya, who is also a board member of the Epilepsy Center. And so I'm going to turn it over to Nicole as she conducts the discussion today. So take it over, Nicole.
Thank you, Roy. Welcome, everybody. And thank you, Dr. Saraiya, for giving of your time tonight. Just so everybody knows, Dr. Saraiya is a local neurologist who sees adult patients and is board certified in the treatment of epilepsy. And tonight we're going to have a discussion about epilepsy in the elderly. So before we really get started, Dr. Saraiya, I think we have two things we need to clarify right from the beginning. So my first question to you is going to be, there must be something to the word elderly as far as epilepsy is concerned. There must be a difference, say, compared to children or adolescents. So can you tell us exactly what that difference is and exactly what is elderly in the world of medicine, not necessarily what we would consider elderly in the general population?
Well, thank you. Good evening, everybody. Nicole and Roy and Betty. I'm privileged to be here with you guys. So to answer your question, Nicole, elderly, there is no clear definition, as you know, as far as the age cutoff is concerned. Everybody's allowed to be young at heart, and everybody's allowed to feel young at heart. But let's face the reality. I think aging does not stop. Your body ages, so the brain ages. And I think we could consider somewhere around someone above 65 or maybe are about 70. So 7th, 8th decade onwards, I think you can put that in that age group of patient elderly. Now 75 or 65 may experience differently, and it is not clear cut, but in the ballpark, that's where we see the age group. So as far as medicine is concerned, the reason why we discuss epilepsy in this age group is that if you look at the occurrence of epilepsy across the spectrum, all the patients around the world, we see this condition clustering more in the younger time frame, from neonates to childhood to early adulthood. And then the middle age group, the new occurrence of epilepsy or incidences of epilepsy don't seem to happen much. But then as the time goes and as person ages, there is a bimodal incidences that we see with epilepsy, and it increases with the age. So, in the United States, we have aging population. By 2040, we will probably have around 90 million older people. So our population is aging, and the aging itself brings its associated comorbidities and complications. And, we'll discuss further how it affects epilepsy.
Great. So you brought up an interesting point about comorbidities or comorbid conditions that occur in the elderly. Can you expand upon that? What are the comorbid conditions that are different in the elder population compared to, say, infants and adolescents?
So as person ages, they tend to accumulate general medical conditions like diabetes, high blood pressure, heart disease, and with that, incidences of strokes go up. Patients have other multiple orthopedic and balance related problems that puts them at a higher risk of falling. that brings trauma and other conditions more likely to happen in older individuals. And on the other side of it, their body makeup or their physiology of their body changes. They have more, they have less muscle mass, and those are the changes that creates how medications would work on them as they grow older. They accumulate these medical conditions, and then on the top of that, they get put on different medications. So they have more medication on board that puts them at the risk of falling, and it's kind of a cyclical thing that piles as time goes. And so it's a different set of situation that we deal with when we are dealing with an elderly patient population compared to the youngsters, where they don't start out with certain medical problems from their early life.
Now we can see why this is such an important topic, given the number of elderly people that are going to be coming up in the next couple of decades, and this is going to be something very prevalent. I want to talk a little more about some of the things that might put elderly people more at risk for seizures. So can we talk about a couple of specific conditions, such as dementia, strokes, whether they be ischemic strokes or strokes from blood clots or strokes that occurred because of bleeding in the brain, and then just the natural aging process that occurs on the brain.
So let me start with having everybody understand what happens to brain when brain ages. So aging brain, if you look at an MRI picture of a brain of a 20-year-old versus an 80-year-old, there is a gross change that we see, and that is called a shrinkage of brain, which is in a medical term described as atrophy. And that's a natural process. Now, every brain, especially when we're talking about epilepsy, every neuron, every single cell of the brain has a potential to be in a state of excitation or a relaxation. So at a given moment, there is a state of excitation or a state of relaxation that constantly maintained in brain. That makes you function, that makes you who you are. At a point in time, in a timeline, that disruption happens. It becomes too much excitability that causes a seizure, in general terms. And so when the neuron's aging, when the neuron's growing or atrophy, the neuron's capacity to decrease the excitation goes down. Its capacity to clear out some of the toxic substances goes down. And all of these makes the aging neuron vulnerable to lose that balance quickly, and that it can cause seizure. That's one of the general theory that we understand. I mean, there's a lot of science behind it, but that's beyond the scope of this talk. So to go back to your second part is that what are the conditions that happens in elderly that puts them at a higher risk of having epilepsy or seizures? So three main conditions that come in my mind. Number one is a stroke, which is the most common neurological disorder that we see. The second condition is a neurodegenerative conditions where brain degenerates due to an underlying pathological process, and that could be dementia, commonly Alzheimer's dementia, other uncommon dementias, vascular dementias, Lewy body dementia. These are all conditions that predispose patients to have seizures from it. And the third thing is some kind of a tumor in the brain. As one ages, it's their chances of developing cancers go high. In these cancers, specifically some common ones, breast, colon, certain pancreatic cancers, skin cancers, they do have higher tendency to metastasize to the brain. And to understand metastasis is like a cancer spreads to brain. So brain, which is affected by the metastatic disease, can also that person can also have seizures from it. So if someone in their age 70s or 80s present to the hospital with their first generalized tonic-clonic seizure, our first inclination is to look for these conditions because they're most common.
Great. So to segue onto that, I have a couple questions that came in, and I'm going to lump two of these together and we can address them separately, but same theme. Two people had written in and said that they had a stroke. One was from a clot or an ischemic stroke, and one was from bleeding in the brain. And both want to know that after a given period of time, when they recover from the stroke, will the seizures also recover? And then subsequently, would they not necessarily need medications for life?
Okay, so let's just understand a little bit the difference between the ischemic stroke and a hemorrhagic stroke. Ischemic stroke is the area of the brain that's not receiving the blood. Imagine a garden without a water hose, and so it's a dry, dead land, that's kind of like an analogy for the ischemic stroke, where there's a lot of water and the garden's flooded. That garden is not also worth of growing anything in it. That means the brain is flooded in the bleeding that occurs within the matter of brain, and that's called a hemorrhagic stroke. Now, the understanding is the hemorrhagic stroke spills out some products that is within the blood, and that product of the blood irritates the neurons more than that ischemic or sort of a dead neuron. So people who have hemorrhagic strokes, they're slightly higher risk of developing seizures from it than the ischemic strokes, but they do both have a degree of risk that they run. Around 6% of the ischemic stroke patients do develop seizures, all ischemic strokes, where around 9 to 10% of these hemorrhagic strokes may develop seizures in the future. Now, once it is determined that stroke occurred due to the fact that they had, I take that back. The seizure occurred because of the presence of the stroke that they had. The guidelines or the treatment protocol is that you put them on an anti-epileptic therapy. Now, do these patients come off of an anti-epileptic therapy or not? Overall, in general, they carry a fair to good prognosis. They do not tend to have too many seizures back to back, as their time passes from the time of the stroke, as their brain changes over time. On the other side, if the stroke occurred in the front part of the brain or the outer area of the brain called cortex of the brain, they are more susceptible to be having seizures from it than those who had a lower part or brain stem or even lower part of the brain, back part of the brain called cerebellum affected. And so in order for someone to take off of seizure medication, there are some guidelines, and these are still case decisions that physicians take. But in general, at the time frame of around 2 to 3 years, if they remain seizure free and their brain that was affected by the stroke does not appear to be a very big area or a very large area with the surrounding scar tissue seen, then you can take the chance of removing their medication slowly. Now, there are some patients who we do not take their medications away from them and keep them for pretty much lifetime. These are the patients who, if their medication levels were low and they had a seizure, or they missed their medicine and they had a seizure, or they ever had a bad seizure that they ended up in the ICU and they were on a ventilator and had a bad course from it, physicians tend to kind of back off from considering taking them off of the medication. But these are all, again, case by case basis decisions, but it's not absolute. They can come off their medications over time if they remain seizure free for several years from the start.
Great. going back to the brain atrophy and neurodegeneration as seen with, for example, dementia, two parts here. Why does brain atrophy increase your risk for seizures? And are there medications that either cause or accelerate brain atrophy?
So good question. So the first answer I kind of partly touched on earlier when we talked about how aging neurons behave, and so is there any understanding why an aging neuron or a neuron that is affected by underlying neurodegenerative conditions tend to have more seizures and those without? Scientific studies are there, and they kind of put their own explanations for that. But I think it still comes down to the overall general health of that neuron or neurons or communications between the neurons, and also some other comorbidities that affect that person's individual's general health. And so, I think to answer the second question linked to this is that, there are there any medications that causes atrophy? Now, most of the anti-epileptic agents that we use, there is there is going to be some where it is written in the pharmacy paperwork or somewhere that it causes brain degeneration or atrophy. It's not true for every single one of them. But some of the older agents, like a phenobarbital or phenytoin, they do have some literature and data on that they can cause atrophy or shrinkage of the brain over time if taken for years and years. Now, on the other hand, there are certain medications that actually decreases the seizure threshold. Remember, we talked about that there's a constant balance between excitation and relaxation, and there are some sort of medications that kind of affect that balance, and a person topples from that balance and then can have a seizure. And some of the medications that are used for antidepressants, such as Wellbutrin, or there are certain pain medications like Ultram or Tramadol, are kind of known to be, very common to do that. Certain very higher level of penicillin medications or antibiotics have done that. So it is to be kept in mind what medications they are on, what are the underlying other medical conditions we are dealing with, or what states are we treating in a person who is elderly, not only elderly, but they also have dementia or dementia-like conditions.
Great. We have a lot of really good questions left, but I want to kind of pause here for a second because there's been an overarching theme that you've talked about since we started. And it seems to me that the difference between the risk for seizures developing in the elderly, we may actually be able to mitigate ourselves. So it sounds like we need to have a little conversation about how to keep our neurons healthy.
Well, that is a different discussion, but I definitely would like to take an opportunity to educate everybody because it's very important. So healthy neuron exists in a healthy body, or a healthy brain exists in a healthy body. So whatever is good for heart health is considered good for brain health. And so that takes us to what are the functions of the brain that it serves to us. It makes us who we are. Actually, it controls pretty much every single thing in your bodily functions. And so there are 6 things that we talk about. And I did not expect this question to come up, but I think I'm gonna ponder on it. The first thing is tell you about is that is a body health, general health. The number 2 link to that is how to keep my body healthy comes to the exercise. That directly links to diet. That directly links to socialization, meeting with people. You won't imagine loneliness kills people. So meeting with people, socialize, volunteer. Those are the things can help sleep and relaxation is very important. Actually, sleep is extremely important even in epilepsy, where, people who get sleep deprived, their seizure threshold goes down because body is in constant state of balance. And the last thing with the, overall brain health is a mental health. Pick an activity that recreates your mental functioning. It doesn't have to be a burden. So be happy is also a part of being a healthy for brain.
I threw that to you just so we could reinforce how important diet, exercise, and overall health is to help prevent stroke in particular, which can help prevent some problems with seizures later on down the line. Great job. Our next question is, now that I've had a seizure, do I have to stop driving?
This is very important and common question that we get asked. Once you have a seizure, whether it doesn't mean, so we need to first understand the difference between seizure and epilepsy. Seizure means a symptom that comes from misfiring of neurons in the brain. That symptom can be anything. You can lose your awareness, you can lose your speech, you can lose your bodily functions, you can shake, you can have convulsions. All of that causes a seizure that makes you lose control of yourself. That's actually a word called seizure, literally. And so if that happens again, second time, or it happens within the 24 hours, it is considered epilepsy. So if someone has a seizure, doesn't mean they're going to have a second one, but they may have it depending upon which age group you look at and depending upon what other conditions you are dealing with. What does it mean for me or a patient where I had a seizure and I can have another one at some point in time? What do I do if I had one while I'm driving? It is unpredictable, and therefore physicians and almost all states have guidelines for that. I don't think there is a state in the United States that does allow patients to drive if they had a seizure. For state of Ohio, we take guidelines from other states around us, and then we tell our patients to don't drive until you're seizure free for 6 months. So regardless whether you take a seizure medicine or not, whatever the reason why you're having a seizure, the doctor has a pretty good idea that this is not going to happen again. This is a one-time thing for you. You took a medicine and the medicine caused the seizure threshold to go down. Medication is taken away from you. However, you still run a risk of having another one. And therefore, we tell patients not to drive until seizure free for 6 months. And it's kind of like a very strict rule we follow.
Great.
Unfortunately.
It is unfortunate, but for the safety of the patient and the public.
Agree.
So I had a seizure, and my doctor says that my EEG and my MRI of the brain did not reveal any reasons why I should have had the seizure, and I didn't have medications that could have caused the seizure. My doctor discussed with me that because this is the first time I've had a seizure, there's not a rule that says I have to start medicine, that we can watch and wait, and if I have a second seizure, I can then go on medication. Can you explain the rationale behind that a little bit?
So that's a very good question. Remember, we talked about earlier that your statistical chance of having another one, regardless of what reason that might be, it's between around 20 to 40%. Now, this risk goes higher if I have a family history of seizure, my EEG is abnormal. In this case, it's not abnormal, or an MRI is abnormal. So in this case, it's not abnormal. So my risk is on lower side of that, on the lower side of that. And therefore, it is to be kept in mind that seizure medications do not come without side effects. They have their own set of negatives. And if the chance is taken for this person to not have another seizure over time and we can watch you, we can avoid that for you. And that is decision that a physician and a patient can take together mutually to understand it properly and to be safe also on the other side. I tell my patients, and this is my personal opinion, I tell my patients that, even if I see you have a very, very little chance of having another one, if I put you on a seizure medicine, I give them an analogy of rain and an umbrella. If there is a rain, it's going to rain. You're going to keep an umbrella with you. The medicine works like that. If it just in case if it rains, you have an umbrella, you can protect yourself. Does it mean that it's not going to rain? No. Does it mean that I'm not going to wet even if I have an umbrella? No. But at least it gives you that sense of protection that I'm carrying with me. And that is a rationale behind taking the medicine versus not.
Great. So this question comes up very frequently and is actually a very common scenario that we see. So I had a highly suspicious event that was thought to be a seizure. My doctor ordered an EEG and my EEG was normal. How can you tell me that I likely had a seizure if my test is normal?
So this is again very common question. The seizure is a clinical diagnosis. If someone had a seizure and their EEG was done several days later, we may not see abnormal electrical activity. EEG is very useful in getting a hint from it that this person might be experiencing seizures in future, or the risk is higher of having seizures because we say a particular type of abnormality. And if the EEG is done during the seizure, when it's really happening, it becomes actually quite a diagnostic test, and we can tell from good amount of surety that this was a seizure versus not. So if someone had one seizure, and if that seizure was witnessed and that witnessed description has been provided to the physician, then a physician, neurologist specifically, especially those who are trained in epilepsy, kind of get a feeling of whether this particular person had a seizure-like event or not. It's a matching of a suspect and a profile. They have a lot of profiles of different people, and then there is a suspect, and they match this. We see this in the TV all the time. So we have those profiles learned through our schools, etc. And we match this with the profile that you just told me. Is it matches, click, then we kind of tell you that, it sounds like it. If it doesn't match, then we question it. We say,
great,
it doesn't say it was a seizure or not, and we need more data, we need more information, or we need more time because it may not happen again, like we talked about it earlier.
Correct. So if I develop seizures later in my life, are my children at higher risk for developing seizures?
So children and related epileptic conditions have a background and an underlying setup for having seizures or developing epilepsy predominantly on a genetic ground. So if a person, or in our case, elderly, or someone who's about, let's say, let's lower the age a little bit, let's say 50 years old, and they had a first seizure in their life, it's extremely rare or extremely unlikely for their children to develop when they are 50. Unless that seizure occurred as a part of certain genetic conditions, which if they were born with genetic condition, you would have seen it by now. So it's very, very less likely.
Okay. I have one more question to finish us out today. And we touched on this a little bit earlier in the discussion, but I want to go back to medications and the elderly, specifically a couple of points. The difference in metabolism of medications as people age, the consequences of polypharmacy or being on multiple different medications, which is actually very common in the elderly, and the risk of increased side effects that we see with the elderly.
Yeah, so very, very good point. it is very important for a treating physician to keep these things in mind. And it is also very important for the patients and their loved ones to know, about it. So as a person age, like I talked about earlier, that their body mass goes down, their muscle volume goes down, and that decreases the volume of distribution of the medicine in your system. Let's say, for an example, I give you a 10 gram of something to be consumed, and then I have a way to detect how many of these 10 grams is in your body and how many of it is excreted in your urine, etc. What stays in your body is called volume of distribution for that particular drug. And so if I gave someone 100 milligram of a medicine, let's say, and I assume that 100 milligram of the medicine is supposed to protect them from having another seizure, up to a certain dispersed in their body less than what I would expect. And so it may, I think that the person, I gave them a right dose and they are experiencing side effects because I should have lowered the dose knowing that age patient population. So it comes to the physicians and their approach to the treatment, but it's important for families to know for the side effects. And so most commonly seizure medication side effects are dizziness, drowsiness. It may cause sometimes them to be high on their medication and they can fall, break their bones. And we've seen these cases all the time. The second thing that also plays in the role is the presence of other medications that interferes with the seizure medication. So for a good example, there is an anti-epileptic medication called Dilantin. It interacts badly with Coumadin, which is or warfarin, which is a common medication for the stroke patient to be on. And so they interact. So one medication makes the Coumadin level go down, they have a stroke. Coumadin interacts with the Dilantin or phenytoin, and that medication level goes down, they have a seizure. So, and so those are the things to be kept in mind. Their livers may not be working as good. They are on other medications that counterbalances or increases the metabolism of the seizure medications, or some seizure medications are notorious to do the increase in the metabolism of other medications. So these are all factors to be counted for when we treat elderly with the seizure medications, and it is to be done very cautiously. Another point that I was hoping to make is bone health, which long-term anti-epileptic use is associated with the bone health, and as people age, their bone health deteriorates, and so they need to be given proper supplements to be taken along with their anti-epileptic therapies, and these are all the factors that affect it. The bone health then causes them to fall, fractures, and so it's a little delicate balance.
Agreed. One point that I think is worth really hitting home is that selecting the right seizure medication at the right dose is not an exact science. And as you mentioned, we don't want to give robust doses of seizure medications. We want to lower them a little bit in the elderly, but sometimes it might not be enough. And the only way we know that is really trial and error. But sometimes we need a little bit of time to get the right dose for the right person because it's different for everybody.
I think that is so correct. And it requires a little bit of a fine tuning. It requires a discussion with the physicians and family members, as most of our elderly, they actually live by themselves. So they need that support also. That, sometimes if they're having seizures, we don't always know because they're not attended. So sometimes, cameras and technology comes to help. And there people have used them to kind of capture some of these movements or motions or monitors that keeps track of elderly and their situations, especially at night when they are trying to get up and go to the bathroom, and bam, they will fall.
The fall alert buttons, very important. Well, those are all the questions I have for you today, and I want to thank you so much for your time and hanging out with us on a Friday night. And we look forward to doing this again. And at this time, I'll turn it back over to Roy.
Yes.
It's my pleasure. Thank you.
Yeah.
Thank you, Dr. Saraiya. Thank you, Nicole. I always feel so much smarter after these Living with Epilepsy series. That is some great information. It was a wonderful presentation. I appreciate it. And we look forward to the next one that we do. So with that, we'll conclude this. And until next time, thank you, everybody, for participating in the Living with Epilepsy series. Thank you.